Good morning, ladies and gentlemen. Maxillary atrophy is classified according to the extent of alveolar bone resorption subsequent to tooth loss. And this is an example, a 3D printed model of one of my patients. And here you see, these are the two most popular classifications we use to evaluate our patient. Severe atrophy either presents as type 5 or type 6 of the Kaywood and Chow classification, or lack of bone in zone 1 and 2, or even worse, with no bone in all three zones of Bedrosian classification. In order to rehabilitate patients with severe maxillary atrophy with dental implants, there are two approaches called grafting and graftless. In grafting approach, there are different techniques, including onlay or interpositional graft, or you should be familiar with the sinus lift grafting, guided bone regeneration, or even the use of titanium mesh. Here are two long-term studies on onlay grafting and interpositional graft, and you can see these two techniques are considered predictable after a long-term period with function. Sinus lift is the most common procedure of grafting in the posterior maxilla. Again, you can see from these two studies by Petrusson and also Starch Jensen and their co-worker, sinus lift are very predictable when it comes to implant survival in the augmented site. Guided bone regeneration, usually we will combine it with other techniques when it comes to the management of severely atrophic maxilla. And again, we can study the publication by Jun and his co-worker, and this provides very valuable insight about the implant survival in pristine bone or in augmented site. And I think most of us agree, if we are using the non-resorbable membrane for guided bone regeneration, we expect to see more favorable results. No doubt, grafting is effective and predictable. However, there are downsides, include donor site morbidities when autogenous bone need to be harvested. Or all these techniques are actually advanced surgical techniques that involve a significant learning curve. And most of the time, these are staged procedures. That means patients have to undergo multiple surgical visits before they are ready for implant restoration. In the graftless approach, nowadays, we have many tools in our hands, including narrow implants, short implants, and tilted implants. Narrow implants can be further divided into three categories according to the implant diameter. This is a study show us the category 3 narrow implants has been used in all oral regions for all indications with very favorable results. Short implants, there are reported advantages include cost effectiveness, lower invasiveness, lower morbidity, and shorter treatment times. With all these advantages, we can also see from the systematic review published by Dr. Panos, and again, we see favorable results with the use of short implant. Of course, short implants should be splintered with conventional implants or narrow implants when we are using them to rehabilitate severely atrophic maxilla. Tilted implants, again, there are multiple techniques, include the inclined implants, whether it is inclined distally or mesially. And also we have these pterygoid implants and the zygomatic implants. The advantage of using inclined implants include this different aspect: reduce the need for extensive bone augmentation, shorten the length of the cantilever arms, which is considered biomechanically favorable. And also, we can reduce the number of implants required to support the full arch restoration. And these two studies also highlight that axial implant and the inclined implant, they share similar survival rate in long term. And for pterygoid implants, again, different studies told us they are good in terms of implant survival. And zygomatic implants, the study published in 2004 by PI Bromark already show us very favorable results when PI were using the zygomatic implants in extremely resorptive maxillary cases. And the subsequent study by Chow and his co-worker also show us very favorable long-term results up to 12 years after function. So zygomatic implant is another very effective tool in our hand when we have to rehabilitate a patient with severely atrophic maxilla. And Edmund mentioned about the ITI zygoma consensus. And we can see in this consensus report, the mean zygomatic implant survival was high, over 96%, with a mean follow-up of over 6 years. And also, we can use zygomatic implants for immediate loading. Again, the survival rate of implant with immediate loading in zygomatic cases is high, and actually it performed better than delayed implant loading. And another study by Davo and his co-worker also demonstrate the significance of immediate loading, because if we look at the time from surgery to loading, if we are using zygomatic implants, we are talking about on average 1.34 days. But if we are doing bilateral sinus lift grafting, then it takes over a year before we can provide the implant rehabilitation. Edmund also provide an in-depth explanation on the biomechanical aspect based on the original surgical technique and the Sager classification. Let's focus on the Sager 4, which is considered to be the most severe atrophic maxilla. And in order to provide immediate loading, we have to take advantage of multiple cortical anchorage along the trajectory of the zygomatic implants. So, no doubt, grafting and graftless solutions, they are both effective. However, if we take patient preference into considerations, shorter treatment time, minimal invasiveness, immediate teeth are usually demanded by our patient. So, if you ask my opinion, nowadays, if I encounter patient with severely atrophic maxilla, then coccygoma is one of my main techniques to treat this group of patients. And with coccygoma, no grafting, single surgery, immediate loading, and at the end, we see happy patients. And more importantly, when we talk about predictability, there are so many studies published already telling us coccygoma works very well in this particular group of patients. One thing we have to bear in mind, hardware continues to evolve. And new product line has been developed by the company. And during this period of time, I recommend you to visit their booth so that you will learn more about zygomatic implants, short implants, and narrow implants. To summarize some salient points of this presentation, firstly, from a patient-centric perspective, tilde implants, narrow implants, short implants, they are effective treatment modality in the implant rehabilitation for severely atrophic maxilla. In the management of severe atrophic maxilla, posterior zygomatic implant and cross zygomatic implant both achieve very high survival rate in long term. And most importantly for our patient, immediate loading is predictable in patients with severely atrophic maxilla receiving bilateral or quad zygomatic implants. Thank you very much for attending this